Hello, everyone, and welcome to today's webinar, Avoiding Infection Prevention Survey Catastrophes. My name is Maria Sigala, and on behalf of all of us here at Chartis Clinical Quality Solutions, thank you so much for joining us today. This is one of our monthly clinical webinars. This is November, Avoiding Infection Prevention Survey Catastrophes. December's topic will be Looking Forward to 2023. And January's topic, Doing More with Less, Streamlined Policies and Documentation. Hope you will be able to join. Before we begin, I'll walk through a few housekeeping instructions. This presentation is designed to be interactive, so please become part of the discussion by typing questions or comments into the Q&A box you see on your screen. Time permitting, we will also call on participants with raised hands, which is located on the reactions menu. Today's session is being recorded and will be available within a couple of days. The handout for today's presentation will be uploaded to the webinar's chat throughout the session for those who joined us late. You will be able to access the recording and handout by going to chartisquality.com, clicking on Insights, going to our webinar page, then locating the Avoiding Infection Prevention Survey Catastrophes webinar. Our past webinars are also available on our webinar page. If at any time you don't see the slides moving or you're having trouble with the audio, try refreshing your browser first. You can also submit any technical questions into the Q&A box. We are here to help you at any time. Thank you all so much for being here with us today. I'll now turn the floor over to Lisa Eddy to begin today's presentation.
Thank you, Maria. Hi, everyone. This is Lisa Eddy, and I'm going to be moderating the program today. And I want to welcome everyone to our program on infection prevention and avoiding survey catastrophes. Just want to say a few things about Chartis Clinical Quality Solutions, formerly known as the Greeley Company, just so that we're all very aware. Chartis provides a cadre of services to healthcare industries. We have the high reliability care solutions, which is part of the clinical compliance and high reliability division. And everything you see over here on the right-hand side of your screen, readiness, response, reliability, that's really our tagline for everything we do at Chartis Clinical Quality Solutions. But everything you see here on your screen, we do a lot in the space of adverse action response. If you have issues with Joint Commission or CMS or any of the other accrediting agencies, behavioral health, infection prevention, which is one of the things we're talking about today, patient safety, all the things that you see here. One thing I do want to highlight in our clinical quality and high reliability division is our environment of care, life safety, and emergency preparedness. When we think of Chartis, or formerly the Greeley Company, we don't normally think of, gee, they have this whole cadre of services under environment of care, life safety, and emergency preparedness, but really, because we're having this particular webinar today about infection prevention and the things that tend to get hospitals and other entities into trouble, many, many things get cited related to the environment of care and life safety. And so we want to just highlight that and bring that to your attention. Also, we have medical staff services, optimization, credentialing, privileging, peer review, bylaws. We have a whole suite of education solutions for hospitals and healthcare entities. And we also have Chartis Workforce Solutions, which is really, we do a lot, and people don't normally think about this, we do a lot of interim staffing for all areas in the healthcare field. So please think of Chartis, and please understand that we really focus on simplify and comply, which means we try to get to operational efficiency in an effective and implementable way. So with that, we're going to move to our next slide. And if you can, we want to know what sort of organization do you represent? So just fill in the little area, the radio dial button, and let us know what particular organization type you're representing today, so that we sort of get to know you, and you as you get to know us. So while we're tallying those, we'll talk about the objectives. one of the things this program today is going to be focusing on, we talk a lot, we've done many webinars, if you're repeat viewers, you know this, on infection prevention and control and problems related to that. But this program today is really going to focus on practicalities, and I think you'll really enjoy it. We're going to be talking about things such as, how do you really get a good handle on sterilization cycle and food safety, storage and handling. Surprisingly, that's an issue that's rising more and more frequently up in survey findings. Environmental cleanliness and safety, and then appropriate use of personal protective equipment, standard and transmission-based precautions. And of course, we are still not completely out of the pandemic, but organizations now are facing some scrutiny from our regulatory agencies on the and how do we really manage epidemic and pandemic readiness. And then we're going to be talking about organizing and networking for success. And I want to focus again, just tell you briefly, you're going to be seeing over and over again in your chat, we have to repost the PDF slides so that people that join late will have access to those. Here's our response to what type of organization. Most of you folks here, 79% are from critical access hospitals or acute care hospitals, very few from psychiatric hospitals, but I want to make sure you understand we're getting scrutiny in that behavioral health area from surveyors on infection prevention. Health systems, 8% consulting and other. So there we go. Thank you so much for that. We appreciate that. And then we'll move to our next slide. I'm Lisa Eddy. I'm the Vice President of Clinical Compliance and High Reliability. I have a background in critical care, nursing leadership, operations, hospital quality compliance, risk management, patient safety, and do a lot of work in the, as we said, the adverse action space. I'd like to introduce Philip Bose. Philip, you want to tell folks a little bit about yourself?
Yeah, I think for the purposes of this discussion, I've been in healthcare for about 30 years now. I have a bachelor's degree in biology and a master's degree in critical care nursing. Spent about 7 or 8 years as the infection prevention director at a 274-bed tertiary care center in Texas. 5 years as a CMS surveyor in the state of Texas, and also about 5 years here with Greeley and Chartis.
Bud?
Thank you, Philip. Thanks, Lisa. My name is Bud Pate. I'm the Vice President for Content Learning at Chartis Clinical Compliance and High Reliability effort. I'm pinch hitting for Steve MacArthur, who couldn't be here today. He's our environmental care specialist, but he's in the road, on the road, taking care of clients. I spent 15 years as a regulator, being over the state survey agency in Los Angeles, then followed that by 15 years with Kaiser Permanente, and now going on 19 years with Chartis, formerly the Greeley Company. And in that, infection prevention has been at the top of our list for all of these 40, almost going on to 40 years here or more. Of my career. So it's a pleasure to be with you today, Lisa. Thanks. Back to you.
Thank you. And again, thanks, Bud, and thanks, Philip, for that introduction. Again, we'd like to know what's your primary role in your organization so that we have a good understanding of your perception of infection prevention from the role that you're functioning in. So if you could just fill out again, radio dial button, what role you fulfill. It's very important for us to understand that, so we know, what your lens is that you're looking at infection prevention. And so while you're doing that, we're going to go ahead and talk about our agenda. Again, this is going to be a very practical program, and we're going to be talking about infection prevention compliance challenges, those things that are the heavy hitters that impact everyone in the organization. And then we're going to talk about making friends and influencing people. And what does that mean? And that's really about, who do you need to be your best friend in terms of infection prevention, and why is that important in the organization? And you'll find out a little bit about that as Philip goes into that in detail. And then we're going to end with keys to success. What is it that organizations really need to do to be successful in their efforts with infection prevention, not just for surveys. It's important for the survey process, but most importantly for the patient. And so what are the keys for optimal infection prevention and control in an organization? So with that, do we have the results of the poll yet? We do. Many of you, 38% are infection preventionists. We have a few nursing leadership people. Welcome, everyone. Other hospital leadership, quality directors, very important role in assisting with infection prevention, and a high amount of regulatory compliance, folks. So we know that you're very concerned with infection prevention, top priority with our regulatory agencies, CMS and Joint Commission. So welcome, everybody. Thank you for your participation in that poll. And with that, I'm going to turn the presentation over to Bud to talk about infection prevention compliance challenges where the regulators are focusing their energies and efforts and some other issues related to that. Bud?
Yeah, thanks, Lisa. So we all know that infection prevention has been in the crosshairs of regulators for decades. But where are they looking at now? What does the data tell us? That's what the next few minutes is intended to share. And this is a map of where CMS becomes involved. And this is from CMS's QCOR database. And these are the conditions of participation that are involved in termination actions for hospitals. So what are the heavy hitters? And you see on the very left here, the heaviest hitter is are issues that are adverse events related, and these usually involve patients' rights and the nursing conditions of participation. No surprise, most hospitals have deemed status, so there's no routine surveys by state agency. And so those things that bring them to the front door tend to be adverse events. So no surprise, that's the top hitter. But right underneath that is infection prevention. It's the second highest condition of participation that's leading to threats of termination of hospitals across the country. So that pattern has not changed for many, many years. We have good data from the Joint Commission as well. And these are just the top 10 of those higher importance issues that are cited by the Joint Commission. As you know, the Joint Commission has the SAFER matrix. And what are the high impact things that are cited most frequently? And that's what this graph is intended to show us. And you'll see that 6 out of the 10 things have to do with infections, one way or the other. The first one I see, 221EP2, has to do with disinfection and sterilization. And that's just the performance of those things. And then that's followed on by EP4 of the same standard that talks about the storage of sterile equipment and supplies, and non-sterile, actually storage of all equipment and supplies. Next up is infection prevention activities, and that's where lack of rounding or lack of oversight or a lack of escalation it sort of is validated by observations of inappropriate use of PPE, surgical attire, et cetera. Then we get into the environment of care citations, a safe and suitable environment, almost 100% of the time in our experience, maybe 99%, not 100%. This has to do with infection prevention issues in the environment of care. Then we have our favorite here, temperature, humidity, and airflow for critical locations. That makes the top 10, as does, now we put hazardous chemicals over there. In fact, the hazardous chemicals standard is cited for eyewash stations, which is very low-hanging fruit, and that's where they tend to cite that. But this is also where they'll cite transportation issues of biohazardous materials, like if you have dirty scopes and things like that, and they're being transported without the rights inappropriately, that's where that would be cited. So that's what the data tells us. in practice, we see, as you can tell from that data, there's a lot of emphasis on the sterilization disinfection cycle. And this is sort of a smush together of those two cycles. So please forgive us if it's not an ideal representation of the cycle, but obviously that involves the actual use of the point of use, and then collection, preparing the reusable equipment for decontamination as a transport as part of the cycle. There's the decontamination process. And when it comes to steam sterilization, there'll be a packaging process. And then there's the actual sterilization itself or disinfection, then storage, and then back again. And we find that issues around sterilization, disinfection aren't just in central sterile supply. They're everywhere. Point of use, collection, transportation, storage, all those things that happen outside of central supply are cited and lead to condition level findings just as often as issues within the central supply department or the surgical service.
And Bud, based on your previous slide, it's not just condition level. By far, there were more immediate threat to health and safety. By far, I think it was 20-1, even over suicidal issues with suicidal patients.
Yeah, let's go back to that slide. Excuse me. So this one is the one I think you're talking about, Philip. So what you're saying is that this immediate threat to life, this, by the way, leads to preliminary denial of accreditation. This is based, by the way, on 2021. We find that in 2021, we were still in the pandemic, but the frequency of these citations by the Joint Commission was twice as heavy as it was in the prior year that we have data for, 2020. We don't have 2022 data yet, but anecdotally, we see this pattern emerging. We're seeing a lot of immediate threat to life around infection, and this is the sterilization and disinfection part of that. And we're also seeing it here in the execution of duties as well for infection prevention. So that's a very significant. So thanks for bringing that up, Philip. So a little bit more discussion then. What else are we seeing that's not showing? Lisa, Philip, are there things missing? I mean, we've already talked about disinfection, high level disinfection, sterilization, temperature, humidity, food handling. Lisa, you brought up this point a little bit before where we're seeing more of this. We have seen it's just anecdotally, we've seen one very prominent institution actually have an immediate threat to health or safety by the Joint Commission and preliminary denial of accreditation, really solely on the food handling practices in that organization, large organization. And they got into the storage temp, food code issues. Anything that's not on this list, obviously we have surgical tire, PPE, just to sort of, and we'll get more into these as we go along. Anything that we're missing, anything you want to highlight?
No, I don't think so, but I do want to bring everybody's attention back to, I think we all immediately think of central sterile processing, high level disinfection, instrument usage and cleanliness and transport and those kinds of things. What we tend to put in the back of our mind, but we are seeing it as a company with our clients, is that environment of care issue that continues to get cited related to cleanliness in the environment. So we just want to continue to draw your attention to that because it's something that, believe it or not, frequently gets cited. And as Bud said, we are noting more and more citations in the food handling storage component.
I see Philip has put himself on mute here. He must be having, Philip is up in Alaska right now, so he might be having some bandwidth problems. So
yeah, I'm having a little bit of bandwidth problem. So if I go silent, you'll know that's what it is.
Okay. Anything you want to add here on this slide?
Oh, no, I just think that, we have seen, I think you probably talked about some food handling issues, but, also just the multiple findings. You can have a lot of findings in environment of care, cleanliness, maintenance that can all add up to one big finding during a survey.
Right. So it's a matter of drip, drip, drip. It's not necessarily one big thing, but it's accumulation of things. Maria, I do see that we have a request for color copies. Sure, we'll forward those to all attendees later. In the meantime, you'll have something to take notes on, and we'll follow up with color copies to everybody. So the next part of the agenda is, okay, so how do you deal with all this stuff? I mean, this is not news. It shouldn't be news to anybody on the phone that these are the issues. We just wanted to really point that baseline. Really what we want to talk about is what to do about it as an infection. And that's not easy. We all know these problems, but a handful of infection preventionists have to influence thousands of people in the organization to actually get their arms around this. So what is the approach? And we're going to turn over to Philip, who's got a lot of practical experience doing just that. In fact, that's what he's doing right now. That's why he finds himself in Alaska today. Poor guy. So Philip, it's over to you.
Well, okay. Well, before we start on, the friends and that you need to meet if you're new to infection prevention, or if you've been around for a while, some people you may need to reacquaint yourself with. We're going to just kind of start at the beginning. When I review an infection prevention program, I pretty much start at the risk assessment. So the whole point of a risk assessment is to identify all those high priority items that you need to be focused on in your organization. Now, the reason we have geographic location on here is because that is a specific requirement of the Joint Commission. So you need to include any items in your geographic location that might affect your infection prevention plan. And those would be things like if you have a university or a college that could bring some Neisseria meningitidis into your facility or things like that. Or you may have a government lab, have some sort of toxic or biohazard waste site in your area. All those things could infect your infection prevention plan. As far as being nimble, I don't think that there's anything we can say more than COVID-19. Throughout the last few years, of course, your infection prevention plans and policies have changed multiple times throughout the year. So remember, even without a pandemic, you have to be nimble with your plan and change as times change. And don't forget, at the end of the year, I know a lot of places where I go, they don't evaluate what they did, where they were, what worked, what didn't work. And that sort of leads into the follow through and the escalation. And you have to do that in a visible way, which we're going to talk about later. But simply, whenever you're going to evaluate the effectiveness of your infection prevention program at the end of the year, you want to see, okay, what's going well, what went well, what didn't get better. And then again, to reevaluate what your biggest vulnerabilities are. Now, anything to add on that, Bud or Lisa?
I think that's great. And I know we're going to be getting into more of that in a little bit. I did want to just jump on here. What you're going to be hearing over and over again, and we'll visit this later, is in order to get all these things, there's the plan and the follow through of the plan, but that plan is going to touch on so many different things. And the plan should be driving your program. And so there are the things that are based on the risk assessment, like surveillance, just managing, collecting data, holding people accountable. Obviously, there's antimicrobial stewardship and emergency preparedness. And top of that, there's a lot of stuff. The list could go on, and we will go on, believe me. But in order to have an effective program, you have to have the right staff. You have to have the right number of the right people. Now, the people with the right qualifications and right interpersonal skills. I mean, interpersonal skills are way up on the list of the competencies for these folks. So of course, the preventionist doesn't have a lot of control over how many people they have or what qualifications. However, so therefore, I should say, what they have to do is get the sponsorship of executives, which is the problem. Now, this is our model. When we go in, we look at all of these things, not just the effectiveness of the program, which is what we typically get, but we look at the staffing so that we can communicate with executive leadership when we think there's a staffing versus effectiveness mismatch. And it doesn't always have to be staffed in the infection prevention program. It needs to be staffed appropriately, but it might be in other efforts. There might be other people, educators, et cetera, who may be able to do some of this surveillance or other activities for them. So I just wanted to touch base on this. You'll be hearing about this model again, but the elephant in the room, guys, is that the effectiveness of the program depends on the staffing to a great degree of your infection prevention program, how skillful they are in impacting the performance of other people. And that is critical to have executive sponsorship. They have to not only talk about sponsoring it, but they have to put their money and their staffing where their mouth is when it comes to that. And I know that you've been dealing with this, Philip. Is this sort of a paradigm that you find useful over and over again when we go in?
Oh, of course, it's a good way to break down the program and look at again, it's the practical, all the things you need to have a program, and then the staffing, I think, is the biggest, the most difficult issue, because it's so dependent upon the footprint of the organization and the services that are provided and things like that. And then the executive sponsorship is pretty straightforward. Either the infection preventionist has a pretty good, pretty straight line to the executive team, or they don't.
Okay, great.
I'm just going to pop in here too and focus everybody's attention again on staffing. And if you feel that you cannot in your organization accomplish what you know you need to accomplish, you do need to engage leadership, and you need to keep escalating till you get what the actual resources that you need. But you also need to be able to give executive resource a roadmap as to why you need those resources, so that it has impact when you escalate. So, but
yeah. So back to you, Philip, and we're now into the Making Friends, which is the main banner for this portion of our presentation.
So I think the point of this webinar is not just to provide it's not really to provide a laundry list of potential problems that we find. Bud kind of let you know at the beginning what we found, what Joint Commission and CMS find. But we do want to highlight the big issues that we find and the things that we look at the closest. And when I think I said this before, when you're a new infection preventionist, or if you've been around for quite some time, you either learn early, you usually learn early that you can't do this job alone. You need to work with other leaders in areas. And we're going to be discussing those other areas and other leaders in the next few slides. Now, all that being said, with all of these leaders that we're talking about, right now I'm working with a relatively new infection preventionist. As you go to these leaders that hopefully some have been there for quite a while, you still need to trust those people, but verify. So as you grow, you may not. I know when I started with infection prevention, I had been in the ORs a lot as a trauma coordinator, but I was certainly not an OR expert. I was somewhat scared to go into sterile processing because I knew almost nothing about it. So when you go into those, you learn from those leaders and you trust what they say, but you also eventually are going to have to become an expert yourself, and so that you can trust but verify what's going on. Because what we find in a lot of places is what we call legacy errors. In other words, these are errors in these areas that were taught 20 years ago and to the first person, and they were taught to the next person and the next, and then 20 years later, you still have that same error that's going on that everybody thinks is the right thing. So we need to watch for those. So that all being said, one of the first and most important folks you need to get to know is the operating room director. And what we look for in the operating room are temp, humidity, and airflow in your rooms. We usually find issues with room turnovers and general cleanliness of the OR in all aspects of that. Surgical attire policies have changed through the years, and we find issues with those, whether it's with different staff. Anesthesia seems to have their own way to do things, and then you may have reps that don't really follow the attire policy. But I already spoke about the point of use care of instruments, which is the very first part of the sterile processing cycle. And so if that very first part is not done carefully, it causes all the other steps in the sterile processing cycle to be more difficult to manage. And of course, the sterile processing staff understand that very well. We find issues with storage of sterile implants, sterile implants particularly, and tissues. But what we find are places that if you go and they have a lot of orthopedic total hips and total knees, just the volume of those implants cause a problem to where you're not storing those in the proper temp, humidity, and airflow, sometimes stored in hallways and all kinds of strange places. And then the last kind of issue we look for is immediate use steam sterilization, which most places it's going away. People are using it less and less. But one of the main things we find is that the less and less you use it, you have to determine who is actually performing the immediate use steam sterilization. Is it OR staff or is it sterile processing staff? If it's OR staff and they're doing it 4 times a year or 4 times a month, then it's hard for them to keep competencies. And so you have to really watch for competency with immediate use steam sterilization.
Hey, Philip.
Yeah.
You've got a question here that I think is very important, and I see problems with this too. What are you finding with OR turnovers? I'll just tell you, I find a lot of cross-contamination. But why don't you, Philip, from your standpoint, talk about that just a little bit?
Yeah, I have to keep things simple for myself. So there are 3 things I look for in OR turnovers, and one of the steps is it actually has a lot of steps, but one is to make sure all the soiled items are removed from the room before the cleaning begins. Again, that goes back to Lisa, you talking about cross-contamination. Get all those soiled items out of the room before cleaning begins. Everybody should perform hand hygiene, change gloves, and then go back in and start cleaning. Now this is the process that's multifactorial, and you'll find a lot of problems, but basically it's top to bottom and clean to soiled. So clean in the proper order. And also, we found where people will take one cloth, clean all the way down to the floor, go back up to the next item and start at the top of that item and take all the soiled stuff from the floor and put it on the top of the next clean item. And then the last point is to make sure you're finished cleaning before you bring clean items in for the next case. And those are that's the way I look at it. And those are the problems I see. And I see problems in all 3 areas.
Hey, Phil, could you explain to me? I'm a little bit slow. People will tell you. Explain to me a little bit more about the cleaning from top to the floor and then going to the next and starting at the top again. Is it because the floor is considered more contaminated? What is the issue there? That's
exactly right. Yeah. I mean, the top of an item should be the cleanest part of the item. It was probably covered with, it was probably covered with, the items you use for the case anyway. The top is the cleanest, and of course the floor is probably the dirtiest part of your room, and the floor toward the middle of the room is the dirtiest part of the room.
Got it.
Right. So
I know. Yeah, go ahead, Lisa.
Just to be really clear, we do not, once we go from top to bottom, go back up with that dirty thing. So that we do see that a lot of people are in a hurry and they just keep wiping with the same rag over and over again, up and down. And so that's something we really want to focus on.
Yeah, I agree. Any other questions on that?
Yeah, I have a few things I want to talk about there. I just want, Maria, can you reshare the slides in the chat? It's not in the Q&A section. Whoever's asking that question, it's in the chat. So Maria will reshare it in the chat just to make sure everybody's got the slides. And like I say, we'll follow up with the color version at your request. Sorry about that. One of the things that still is a problem or a challenge is this airflow, temperature, and humidity. And there's a disconnect between so when we deal with this, and it's in the OR procedure area, the disconnect is somebody comes in and takes the temperature or the humidity in an OR at the beginning of the day, and then and because it's silly, they don't go back and actually, they'll have a bad reading, they'll log it, and then nothing will happen about it. And remember that the APIC and everybody and ASHE and all of the expert groups from across the country have clarified that the parameters around temperature and humidity, at least those things, are design criteria built on the FGI guidelines. They're not operational criteria, but your HVAC system, depending on when it was installed, needs to be up to the FGI criteria and be capable of supplying air at those at that temperature and at that humidity. And so one of the disconnects here is we're measuring humidity and temperature inside of a room as opposed to at the supply duct. And that's really where you want to measure it, is at the supply end, not within the room. And so when we're dealing with this is the first thing we do. Now, not every hospital has the capability of doing it that way, but that's what needs to be done. And then we really need to think carefully before we overcommit and underperform. So if anybody's having difficulty with that, just leave a comment here or email us, and we'll send you our model guidelines as to how to handle that. In the procedural setting, there are obviously, there's one other place that folks get into trouble, and that's usually the airflow behind to the equipment room or the decontamination room into the sterile processing room or other sensitive areas. And that airflow, checking that airflow, that's just a problem. It's like painting the Golden Gate Bridge. Once you get done, you need to start over again. And because the air balancing of those is very sensitive and very multifactorial. So that's something you just want to check regularly, especially if it's in your survey time, because you know that they're going to go and do smoke testing or something else on the airflow. Sorry to take up too much time, but I had to represent Steve MacArthur correctly, and he would be all over that.
Yeah, I think that's very, very good.
I just want to point out, guys, I've got a message here saying that chat is disabled. And I think Maria and Tynesha on our IT end will be working on that. But go ahead, Philip. Let's keep going.
Okay, well, just moving on to your sterile processing director. Just when you just look at the processing and storage portion of the AAMI guidelines, the ST79, it's only about 250 pages of regulatory goodness. So it's one of those things that, you can just pick that up really quickly, just with a light afternoon read. We could spend 5, 10 hours, 20 hours talking about just sterile processing, what we need to look at there. But, it's all things processing and storage. Airflow, again, you have issues with airflow, positive airflow in your clean side, negative airflow in your soiled side. Same issues with temp and humidity, especially over on the clean side. And when we talk about instructions for use in preventive maintenance, where I find most problems are not with your annual or semi-annual PMs that are either done by, one of the, I'm trying not to mention names, but one of the large manufacturers. They usually are pretty much on top of it. But it's the daily, weekly, monthly preventive maintenance that's in the instructions for use that would be performed by your sterile processing staff. We see that those things are often not being done because we do not know what our preventive maintenance schedules are in there. And so those are the big issues that I find in the sterile processing area, without going into a long dissertation.
And Philip, before you move on to the next slide, I really do want to point out, when we talk about friends in the right places, it's really important for the infection preventions to make a connection where the operating room director and the sterile processing director feel comfortable inviting that infection preventionist to come and take a look or pick up the phone. So I've got a question about this. I need help with that. I need you to come in and take a look. It's really making that connection so that these individuals, and Philip's going to go through some more friends in the right places, but it's about having the partnership that's really needed with the infection preventionist for these various other roles. Philip?
Yeah. If I can just jump in here on a slightly different tack here, one of the things that you might want to consider doing, and you need to do this collaboratively with everybody, is break open those packages and look at what the instruments actually look like after they've been processed. And you have to do it in a way because you don't want to be, these folks are your friends, right? And you don't want to embarrass them. So, but you want to do it together. Okay, well, let's see what these, how many packages of these equipment do we have to send back? What do they really look like? That's something that is really the bottom line when it comes to sterilization. Is there corrosion? Is there, are we removing burden? All that kind of stuff is important. I just wanted to put that in there. I don't want to take too much time because I see we're moving on, but I know that we've had big problems with that at some of our clients.
Yeah, where the rubber meets the road is what the instruments look like with rust, etching, corrosion, tape issues, all of that. I agree.
Okay. And so, and by the way, Deborah, we will share those temperature and humidity guidelines with the registrants at the conclusion.
Okay, so your next friend there would be your pharmacy director. So sterile compounding is a big issue with infection prevention. You have your vent hoods, you have your air and surface testing, you have your media fill testing that's done annually with the folks that do sterile compounding, and also your fingertip testing. All those things are important that your pharmacy director is going to help you with. Which medications have multi-dose vials throughout the hospital. You're going to need to know what that looks like for infection prevention reasons. Drug storage and temperatures, just like sterile processing, sterile item storage and temperatures. Just medication administration, med passes, and the way blood is handled. And then lastly, and it's another large portion of the infection prevention pharmacy friendship, is the antimicrobial stewardship program. Usually you have a pharmacist that's running that program, and we always look to see how they are interacting with infection prevention, because as we all know, CMS just put, in 2020, they put all of those antimicrobial stewardship requirements in with the infection prevention requirements.
And as we're going through these slides with each of these people we're making friends with, what I'm thinking, Philip, and I don't know what your thought is that if I'm a preventionist or the director, especially of a larger department, I would have routine meetings with all these people that's sort of fact-based as much as possible in a collegial way. Say, well, this is what we're finding. I would just go to their office and meet with them to talk about the issues and to problem solve. And why wouldn't that be reflected in the way some of our infection prevention plans are created? Does that make sense?
Well, sure. Yeah. But as we all know, most everything that happens in a hospital doesn't seem to happen during committee meetings. It happens in those interstitial periods between the meetings where the actual work gets done, where the collaboration happens. And so, of course, that's correct.
And we do, before we move on, we do have to keep moving. We will share, we have a request to share an IP risk assessment and sort of a template for a plan. We're happy to post that for you. So. Well,
okay, so very quickly, hemodialysis is one of those things. I really knew nothing about hemodialysis until I became a CMS surveyor and then was trained. But hemodialysis is one of those things, unless you've worked in it, there's really not a whole lot that you know about it, more than likely. But for hemodialysis, there's water system management. It's about half technical and about half infection prevention issues with hemodialysis. When technical, I mean, how do you produce the water, and is it good water, and is it adequate, and how's the machine run, and all that. The other part is about, you know, disinfection of the dialysis machines in the water treatment system, the cultures and endotoxin, how to read those, and how often they need to be done. And then just observing staff accessing grafts and fistula and lines, and how they're administering medications and things like that. So it's sort of like sterile processing in the OR. It's an entity into its own, and you really takes a while to learn about a hemodialysis area.
Yeah, and Philip too, I just want to point out that when surveyors, they observe hemodialysis, they're going to look for cross-contamination between the individuals that are managing patients. So just be aware of that issue.
Moving on to food nutrition, and this is sort of a new one that's kind of reared its head in the last, what's really not new, but it's sort of reared its head lately, that, at least with our practice, is that we're finding a lot of issues in food nutrition in kitchens, I should say specifically where food is prepared, where finding in condition level findings and immediate threat findings with all these items you see here: food labeling and dating, the first in and first out, making sure we're using the food in the right order, food temperatures, that's prep temperatures. You know, are we getting the food up to the temperature we need to kill the bacteria and things like that? Food handling and storage, there's also holding temperatures, which are different, and storage temperatures. A big one that we're seeing just about everywhere we go is what we call the hot food cooling log, and that's where you have a big pan of lasagna that you need to cool it down within a certain amount of time. We won't get into the details, there's specific ways to do that and logs to do that, and they're always difficult to do. And then in just the general sanitation and maintenance of a kitchen, it's just a tough place to keep clean because it's always working in a facility. And lastly, I will just say, just double checking, you have your FDA food code, which is, again, that's only about 750 pages to read. To me, one of the most difficult things to look at because it is so long and so detailed. You have your local and state food codes that you have to look at. And so it's a difficult area. Anything to add, folks?
No, other than you're absolutely right. We've seen immediate threat, like we talked before. We've seen immediate threat to life's preliminary and denial accreditation on this issue alone. So go ahead, Philip.
Okay. Environmental Services Director, that might be one that sort of, with environmental services, we need, as infection preventionists, we need to look at waste flow through the facility, sort of track how it goes out of the facility. High level dusting, by that we mean pretty much dust over my shoulder height, over my head. We find issues everywhere we go with that sort of thing. And then just low level disinfection of all the surfaces. And that's, again, just general cleanliness of the facility. This is where our friend Steve MacArthur would say there are two ways you can be harmed during the survey. One is by trauma, which is one or two big things that happen during the survey, or death by 1,000 cuts, which would be just kind of the general state of the environment of the facility, where if they find hundreds of issues there, you can have really bad problems.
Hey, Philip, we've got a very important discussion topic by an attendee, which we will get to as we go through the rest of these slides. It's really, how do we put our efforts in the right area and get leadership to really acknowledge the needs that we have for infection.
Yeah.
We'll talk about that as we go through the program.
So we'll get to that, because you're absolutely right, commenter.
Huge issue.
Yeah, huge issue.
Right.
Huge issue.
All right, so I'll move on through these last two. And so Plant Operations Director, this is a really important one. We have these pre-construction risk assessments, the ICRAs, infection control risk assessments, and ASHRAE has kind of now put together a risk assessment where the interim life safety measures assessment is done with the ICRA. I really like that because it works well and it kind of helps the infection preventionists work together with the plant operations. You also want to help the best you can help plant operations with project and work order prioritization whenever they have a lot to do. You know, they need to know that a hole in the wall in an OR suite is going to take priority over the painting that needs to be done in the administrative offices, because you really shouldn't be doing your performing ORs with a hole in the wall so that rodents or whatever and lose the proper airflow in your ORs. So you need to help them with the prioritization. We talked about temp, humidity, and airflow. And again, as Bud pointed out, the issues with just where you measure it. Another thing we find is that the local staff in this, let's just say the operating room, they think that plant operations is measuring it and taking care of temp, humidity, and airflow. Plant operations thinks that the local staff in the ORs are taking care of temp, humidity, and airflow. And so it turns out nobody's really acting on anything in a lot of places. And then also you just have the issues, especially with COVID, with your airborne infection isolation rooms that you're going to work with plant operations, amongst many, many other things. Any other comments for that?
No.
No, I think we need to keep moving there.
All right. And then lastly, just you got to know the nursing facility. We talked earlier about local ownership. Your nursing department directors, you know, the general cleanliness of their areas, they need to try to help look after that. Medication administration issues. You're going to implement bundles for ventilator-associated pneumonia, CLABSI, CAUTI, all those things. And you just need help because then, of course, lots of things fall upon the nursing departments, but you just need some help from the nursing department to implement the program. And I will just say one last thing is you need to have a friend in the lab, because any infection preventionist, not so much that there are a lot of lab findings during the survey. It's just that you really need a good relationship with your lab, with microbiology and lab in general. Okay.
So let's move to keys to success. So what are we going to do to really get into compliance and stay there, Bud?
So this is one of the big things here, and we're all going to discuss, and hopefully we'll answer that big question that you were talking, we discussed earlier, that's in the chat. But one is round. So those high-risk clinical areas where you have high-level disinfection, sterile processing, and just as much as you possibly can round in those areas. Other clinical areas at quarterly, non-clinical areas annually. If you have off-site areas, you really need that, like an off-site laundry. You need to at least go see what their processes look like at least annually. So if you find that you're not able to get if you're sitting behind a desk, you're stuck behind a computer screen, reporting things to state and federal officials, local officials, maybe there's a staffing issue there. And I know, Bud, you had some thoughts about this.
Yeah, if you can't get out to do the roundings and make these, it means that something's going wrong. You're either doing tasks that you shouldn't be doing, or you just don't have enough people, which is usually the case. And so the issue then is how do you deal with that? And it's very difficult. You have to have the attention of executive leadership, which is so hard to do. But what we're finding recently is getting a little bit easier, especially when you combine it with the hospital-acquired infection conditions, the hacks, things like that. Be lobbying up. You need to be a lobbyist. And we have, we'll talk a little bit more of that, but without executive sponsorship, without an understanding of how can we free up people to do the rounding, you're not going to be able to get out there. And we'll talk about that in a little bit, because getting to our questioner's point here, there's other issues.
Yeah, that question came at just at the right point. Don't let me step on, Lisa, if you had something to say.
No, we want to be able to get to all the slides.
Yeah.
I do want to point out our one, we have a big question here, a big comment here about not being able to get everything done in the infection prevention role, and that other individuals need to be responsible for taking control of infection issues in their area. And that's something that we're going to just identify on in just a minute or two.
Yeah. So So round to identify issues and then escalate. If you keep finding non-compliance, you need to escalate, whether it's through daily huddles, you have executive team through structure, do you report directly to somebody that's in an executive leadership role or not? You have to figure out a way to escalate these issues. So back to who is responsible for, and this is who's responsible for having an effective program. Well, if you look at the CMS requirement, they say CMS and Joint Commission say the governing body and the hospital executives are responsible for making sure the program is effective. And we'll just very quickly talk about working with QAPI folks, because that's your oversight mechanism, and that's how things escalate up through to governing body and medical executive committee, is usually through QAPI program. And also they can help you with data, and they're advocates for quality and safety. And then lastly, I think this kind of comes to the question that we found in the chat, is that you must have local ownership. The preventionist is the finder as much as possible, not the fixer. They can't be that. So the departments, again, I think I'll just read, the infection preventionists should not be accountable for the kitchen. No, they're not so much accountable, but they should be be a finder for the kitchen to find issues. But again, the department itself, through executive leadership, to fix those issues. And so the infection preventionist therefore identifies and escalates persistent noncompliance. And I know Bud and Lisa, you have more to say about that.
I do. I want to just pop in here and say, we need to shift some of the burden, if you will, from the infection preventionist. It's very important for that individual to get down and get their eyes on the prize, if you will. But you can also leverage your position by giving people in EVS or in the kitchen or whatever a list of the things that within their scope of understanding, they can identify and submit to you, sort of like a monitoring that lets you know whether they're on target or off target. So, and I think I'm going to stress the fact that I do believe it benefits the organization to have infection prevention rounding, but you can also leverage that to some degree by having some of the nursing shift do some of the rounding on their own unit, self-identifying issues. So it's very difficult, but you want to talk about that in terms of leveraging up the leadership and how important.
Yeah, I mean, it's a tough issue, but the reality is that everybody looks at infection prevention when there's an infection prevention problem instead of the people who are responsible. The infection prevention are the subject matter experts. They are the monitors and they are the approvers of things, but they don't implement these things. Bundles are implemented by medicine and nursing. Cleanliness is EVS. Use of PPE is everyone. I mean, these are and so they can't, in order to get the influence, they have to have visibility. They have to have be reporting on significant things, not nitpicking, and reporting that on up through the oversight structure to the executive team. That's who needs to receive this message that we have problems. And there's just no substitute for that. We're running a little bit out of time, unfortunately, but we can have offline discussions as to different strategies. It depends on the situation, but there's really no substitute for the notion that the infection preventionist is the expert. They're the identifier, and they're not the solver. They're not the person who can make things happen. And that is a problem that has to be addressed and resolved.
So, but I do want to just ask you and Philip in a minute for your closing thoughts, but I want to bring something, sort of escalate something in this conversation. The infection preventionist is the individual that if you are at the level where you need to go to even your CEO and say, there is a train coming down the track. I brought this, and it's going to flatten people. I brought this attention to this individual and this individual within your escalation team. And they've said to me, well, we haven't had any foodborne illness issues in the kitchen or surgical site, for example. Our surgical site infections are at normal or even lower than the average, but you're finding bioburden on instruments, or you go in the kitchen and you find a hot food cooling log is not being kept or kept incorrectly or whatever, you have to continue to escalate if you're finding situations that impact patient safety. And so I would encourage everybody, as Bud said, you're the finder, not the fixer. You may have recommendations and suggestions for fixing, but if you're not getting the response you need at the various levels, then you need to continue to escalate and make sure that you are giving information in data that in a way that allows your executive leadership to respond, so that they don't think, oh, it's just anecdotal, because that happens frequently. So, Bud, Philip, any closing thoughts?
Just if your leaders need horror stories, just send us an email. We'll give them plenty.
Well, that train comes down the track really fast.
Yeah.
Yeah, I think my closing thought will just be kind of that last slide around local ownership. And if the local folks aren't going to own it, then you have to escalate it. That's all there is to it.
And if you've escalated and you're not getting anywhere, and you've escalated to the top, you've got your record of escalation. You've got if you have data and you've reported it, that's really.
So Maria?
Fantastic. That is all the time that we have for today. I want to thank Lisa Eddy, Philip Bowes, and Bud Pate, and all of you for a lively and informative discussion of this important subject. As we mentioned, the Chartis Clinical Quality Solutions team will follow up with a response to any questions we did not get to during today's Q&A. To learn more about the content presented today, please fill out the post-webinar survey. Thank you for joining us today, and we hope you have a wonderful afternoon.
Thank you. Bye-bye. Happy Thanksgiving.
Thank you.